Hi, this is Dr. Amber Buhler, and we're going to talk today about a very broad and basic overview of what we know about the neuroscience, the genetics, and the expression of autism spectrum disorder. When we think about autism spectrum disorder, we're going to think of it as having a few different components. We think about it as having a language component, a social perception component, executive function, motor skills, and sensory filter. And when we talk about language, we know that language can include verbal language and other ways of social communication. Social perception has to do with understanding how other people are feeling and interpreting their verbal and sometimes body language. Executive function has to do with a lot of different things in terms of cognition, working memory, ability to focus, ability to express self-control, and multiple other things. If you're not familiar with executive function, I have a link here that I would highly recommend you look at. It's fairly short. Motor skills, we can think about reflex as well as coordination, and then sensory filter has to do not only with the input of sensory transmission, which we think about as our sensory nerves, and not only the way that that is processed in the brain, in the sensory cortex, but also the way that we filter out extraneous sensory information. So if you're sitting in the front room and the TV is on and the refrigerator starts going and somebody puts on the dryer and you're hearing all these different things at once, how are we able to filter those out so that we're focusing only on what we want to focus on, say the TV, and not being distracted by the other ones? So these multiple different functions we see very commonly affected in ASD. Diagnostically, what these end up looking like are people with deficits in social communication and social interaction, as well as sometimes restricted and repetitive patterns of behaviors, interests, and activities. One of the things that's really important to know about ASD is it is a syndrome, not a disease. A syndrome means that you have a set of symptoms or characteristics that you often see together, and that you kind of put these together, and when someone has this kind of group of symptoms, you consider that a specific diagnosable disorder. The thing about that, though, is that sometimes people can have very similar symptoms, but because of different causes. And so that's what we see with ASD. There's no specific genetic cause or environmental cause, and the neurological changes in people could be somewhat different, all leading to effects in some of those major 5 groupings. So because of these different 5 realms, what we see are some specific functions and some disorders or comorbidities. So the social cognition and social perception can express itself in lack of eye contact and difficulty recognizing other people's emotions. This isn't the same as not caring about other people's emotions, but having difficulty in understanding or picking up on body language and facial expressions is fairly common. We also have differences in sensory sensitivity in terms of some people actually feel sensory inputs more strongly, some people feel them less strongly, and like I said, the sensory filtering, there's differences in modulation of those. Despite the fact that some people can have a lot of sensory sensitivities, somatic pain, which is just the regular pain if you stub your toe, often is decreased in people with ASD. It's common to have some verbal language difficulties, and those can be expressed not only in difficulty verbalizing, but in some people who are very verbal. There are also some changes in pragmatics and structure. Motor and balance deficits can often be seen. We can have difficulties in sleep, and there's some other disorders that have high co-expression with ASD. A lot of people with ASD are also diagnosed with ADHD, and a high number of people who have ASD also have some form of intellectual disability. Obviously, that is not the case for the majority of people, but quite a large minority do suffer from this. We also see a large percentage of people with ASD have epilepsy, and it's very common to see GI disorders and, interestingly enough, increased inflammatory functions and increased immune system functions. So when we look at one of those major realms affected in ASD, we were talking about social cognition and perception. And we talked a lot about how facial and social stimuli can be difficult for some people with ASD. And a lot of that has to do with the actual difference in cognitive processing of these. So regardless of how empathetic a person with ASD might be, they might have trouble interpreting facial signals that express emotion, as well as body language, which, as we know, has so much to do with social interaction. So these changes actually occur very, very early in development, and understanding facial signals and eye tracking are things that occur just in the first couple of months of child development. So when you look at infants, you can look at how much eye contact they're making under certain situations. And in the photo here, you can see results from infants who will be later diagnosed with ASD versus infants who will not be diagnosed with ASD. Up in the top here, we have a person who's speaking. And in the ASD cohort, they're really primarily focusing on the area that's moving, whereas the neurotypical infants are focusing on the eyes. When hand movements are added in, the ASD infants are focused again on the movement instead of the eyes, where the neurotypical infants are focusing. So if you are a 2-month-old infant and you are focusing on the movement regions and not focusing on the eye and more subtle communication cues, then the brain is not really able to develop those skills of interpretation of facial emotion. So some of the things that we see during infant development are going to be decreased eye tracking, like we were speaking about, also decreased orientation to faces, decreases in pointing, decrease in spontaneous imitation of what people are doing, decrease in orientation to their name, and as we said, interpretation, but also production of emotional social facial expressions. We also had those effects on the motor and sensory systems, and we mentioned that not only do we have sensory transmission and motor transmission changes, but also those filtering issues with sensory. If you have sensory input changes, then motor output processing is also impacted, and you can often see changes in coordination, balance control, postural control, gait, fine and gross motor function, and then also interpersonal synchrony, which is kind of a combination between the motor function and that social communication function, and refers to when someone has certain body language or posture, you subconsciously model that posture. We also see that altered sensory sensitivity, and that is very, very common. Over 96% of children with ASD have some kind of altered sensory sensitivity. We often talk about hypersensitivity, and that's very common to see people who are highly impacted or sensitive to the inputs around them. But we also see that sometimes people have hyposensitivity to different sensory modalities. And the same person can have hypersensitivity to one modality while hyposensitivity to another. And again, we see hyposensitivity usually to pain. With that altered sensory input and altered sensory sensitivity and the alterations in filtering between different inputs, it can be much more difficult to process multiple sensory inputs. And so it can be very difficult and sometimes very unpleasant or even painful to have all these multiple sensory inputs coming in. And it can often overwhelm people with ASD. And they can show patterns of behavior that are very negative or self-harming as a result of that sensory overstimulation. One of the things that's often seen in ASD as a result of this overstimulation is stimming. And that is when a person is purposefully creating a sensory stimulation for themselves so that they can kind of focus down onto that. And some people bite things, some people rub things against their faces. There are many different forms of sensory stimming, but really the whole point is it's helping you focus down on a single input, on that input, so that you're not so overwhelmed by others. So we refer to autism spectrum disorder as a spectrum. And what we mean here are two different things. One is the severity of symptomology, but then also we're referring to different combinations of these symptoms. And so if you have these 5 different groupings of function, people are going to have different amounts of impact on different functions. So when we talk about spectrum, we're also talking about this difference in skills and presentations between different people with ASD. These differences in presentations are, of course, going to mean that working with anyone with ASD, they're going to require different things. So there is no one ASD. One of the things that we need to keep in mind is that there's been a big change in how we're referring to ASD. So now we refer to it as a spectrum disorder. That used to be referred to as autism versus Asperger's, and people kind of looked at them as different things. So people in the public are often still going to have this perception. And this perception has really been given to people by the popular media. So what's important to know is that diagnostically, we do not separate those. Autism spectrum disorder is now containing what used to be called purely autism, what used to be called Asperger's, and then what used to also be called pervasive developmental disorders, not otherwise specified. So Asperger's no longer exists as a separate classification. So for me as a neuroscientist, I'm very interested in what underlies ASD. And we know that genetics are the majority of what underlies ASD risk. And when we talk about genetics, we mean the genes themselves. We know that this is the case, and ASD can often run within families at a higher frequency. We also know that genetics is often not enough. We also know that there is some environmental component, and we're not really sure of what those components are. But it looks like things that impact inflammation and immune system in utero may modulate the neurological development. We know that things we call growth factor modulators may be involved. And these are things like different hormones and some cancer accelerator agents. We also see oxidative stress and different types of toxin exposures. But as I said, we don't actually have any of these narrowed down enough to really clarify them. Epigenetics is really where this all ends up coming together. And epigenetics is how those genes are actually expressed. You can have genes, but not every cell is expressing every gene in the chromosome. So each cell needs to have some mechanism by which it controls which genes are expressed. Those mechanisms can be impacted by the environment. And so these environmental factors can likely come in and change which of the genes are being expressed. And so if you have a combination of genetic risk, here that 80% effect, plus you have some effect of environmental risk impacting that genetic expression, that's going to be an important part of neurodevelopmental changes underlying ASD. And again, this is a syndrome, and it can have different combinations of causes in different people. So these genetic and environmental components can come in different combinations. What we do know about the genetic links are that there are heritable gene variants, and the heritable genes are just what you normally think of. You have one allele from your mom, you have another allele from your dad, and you're inheriting different ones. And we know that there are hundreds of moderate or low risk genes. There are also some high-risk genes, and those genes are usually also associated with other clinical disorders. 25% of cases of ASD have some association with another heritable clinical disorder. And we also have de novo mutations, and de novo just means spontaneous mutations, mutations within the egg or the sperm that then get passed down to the child. And one of the things that is a factor in this is parental age. So as the parent gets older, both male and female, you have more spontaneous mutations in the egg and sperm cells. That's much more common to be occurring in the males, and sperm mutations are seen in 20 to 25% of people who have ASD. So that's a big component. What we want to think about is that the genetic part of ASD risk is polygenic. And that means you have to have multiple genes that all come together, each of which has a different amount of risk. And they all come together and have to end up adding up to enough risk to develop the syndrome. Just to give you a visual of what that might look like, say you have multiple alleles of different genes, and each of them has a different risk score. So there's some genes that if you have this allele of it, it gives you a little bit of extra risk for autism, but not much. And there's other ones that might give you a 20% extra risk. And there's some that maybe are very high and might give you an 80% extra risk. Any one of these alone isn't going to be enough. But if you start adding together different combinations of these, then you may hit enough risk to go ahead and develop. And that's what we mean by polygenic. So we have these different risk genes that we're aware of, and we have this set of multiple types of symptoms. So we have to ask ourselves, what are the common factors that might explain these different symptom groups? And when you look at all of the first symptoms here, all of them are associated with the central nervous system. So we can look for genes that are involved in neural development. GI disorders might sound a little different at first, but the GI requires neurotransmitters. So we see serotonin, we see dopamine, and we see other neurotransmitters that are actually producing the peristalsis in the GI. So if you have neuronal developmental changes, those are also going to affect your GI. And then lastly, we have increased immune or inflammatory function, which may seem removed from neuronal development, but actually immune cells in the body impact neuronal development and anatomy in the womb. So this diagram looks scary, but I'll explain what this is talking about. In a study where they took 659 genes that are associated with ASD, they went together and kind of clumped them together into what the role of those genes were. And so the big red circle here under ligand receptor neural interaction meant that there were a lot of genes that had a big component of risk for ASD. These little tiny blue ones meant that there weren't that many genes and they had lower risk components. So when we look at what the functions of these genes were, we can kind of group them together and say, wow, there's a lot of genes here that have to do with neural development. There are a lot of genes that have to do with cell signaling, and there are a lot of genes that have to do with cell growth. These genes also overlap with cancer, just because cancer is also a disorder of cell growth. So when we think about the neuronal anatomy and function that we see with ASD, we're seeing changes in number of neurons, we're seeing changes in neuronal transmission, cell structure, and cell signaling, all of which are really clearly going to affect neuronal function. The actual anatomical and functional changes that we see when we look really support and help explain some of those physiological and neural symptoms. In the ASD brain, we see changes in neuronal anatomy and we see changes in the number of synapses. You can see here in a neuron that came from someone with ASD, you have this increased number of structures that have synapses in them. We see, if we look at functional MRIs, that there are regions that have increased or decreased activity between people who have ASD and people who are neurotypical. We see that there are changes in connectivity between different brain regions and within brain regions. And we see that we actually have changes in neurotransmitters and receptor numbers. One of the things to take away from this is that some of these changes have to have occurred early in fetal development, as some of these pathways and neuronal anatomy are actually being set down in the first trimester. So we know from this that these different changes in neural anatomy have to be starting very early. Also, not everyone has all of these changes, and so we may end up finding that people with certain types of changes are a certain subtype neurobiologically. So we know that changes in neural development are occurring in utero as early as the first trimester. So what can we see in infants? By a month old, we can see differences in the head righting reflex as well as the plantar response. In early infancy, we can see that decreased eye contact, differences in balance between excitatory and inhibitory neurotransmitters. By 6 months old, we can see changes in head circumference and in white matter tract structures. And those are the neurons that are connecting one brain region to another. So if these changes are actually there this early on, why are we not noticing ASD symptoms until toddlerhood? And really the answer to that is that parents and caretakers aren't generally going to notice those symptoms until around age 2 or 3, because children at that point are naturally undergoing very significant changes neuronally and increasing their function. And so it's much easier to notice these changes once you're expecting a certain level and rate of development. So there are a couple big questions we have when we think about ASD, and one of them is a big argument as to whether there's been an increase in the incidence of ASD. The other one is how strong is our gender bias in terms of diagnosing ASD in males. So it's inarguable that we have a huge increase in the diagnosis of ASD. And you can see that in this graph, that diagnosis rates in 1999 versus 2000 rapidly increased and have been on the rise ever since. In this graph, we are reporting diagnosis and their prevalence in 8-year-olds. So this doesn't take into account any diagnosis that might occur in teenagehood or adulthood. So questions that we have are, we know that this diagnosis is increasing, but is there an actual increase in the number of people who have ASD? And so we're asking, is there an actual increase in incidence? Another factor that could be impacting increased diagnosis could be that we know that there's increased screening. As society is more aware of ASD and its presentation, many more people are going in and being screened and diagnosed. There's also the factor of having wider diagnostic criteria and diagnostic substitution, and we'll talk about those. So like I said, we know that screening increases. We also know that we have had broader diagnostic criteria. Down here in this bottom left-hand corner, the stars here are different versions of the Diagnostic and Statistical Manual, which is really the accepted form of diagnosis. So we have these different editions of the manual coming through. And then in the year 2000, the DSM-4TR came out, and that made a huge change to the diagnostic criteria for ASD and made it much more easy to diagnose ASD. And since then, we've seen that huge increase. And we have people who were not previously diagnosed who now are diagnosed based on those new criteria. So we know that that is responsible for some increase. We also know that diagnostic substitution is responsible for some, and that means someone who would have previously been diagnosed with one disorder is now being diagnosed with autism. And this is a great graph because this shows from year 2001 to 2012, and it shows the incidence of diagnosis with intellectual disability versus autism. And in 2001, there is a much higher diagnosis of intellectual disability than autism. In the intervening years, people were less likely to be diagnosed with intellectual disability and more likely to be switched or given a new diagnosis of autism instead. So that diagnostic substitution is also a factor in this increase in diagnosis. What we don't know is whether there really is a difference in incidence. And this is still under strong debate in the autism research community because there actually, surprisingly, haven't been really good studies that have delved down into that in an appropriate way. However, as a neuroscientist, I'm always looking at the data, but I saw this quote which really made me step back. And it said, in terms of ASD, people tend to look at data as either there has been an increase or there hasn't. And the data are insufficient. We can't really draw a conclusion. So we have to remain open to the possibility that there is a real increase. But what really hit me was commitment to either position is not necessary to use that data to advocate for improved services. So in the end, as a healthcare provider, it doesn't really matter whether this is increased or not, as long as you're caring for the people that come to you. The last topic that we're going to talk about is gender bias in ASD. And traditionally, we've accepted that males have a much higher rate of ASD than females. In fact, the diagnosis rates are 4 to 1. So again, we ask ourselves, why is that? And there may be a risk that increases the likelihood of ASD in males. However, there are other things that could impact these diagnosis rates as well. We know that males and females have different symptomologies. They express ASD in different ways sometimes. And we know that male presentation is how we developed diagnostic criteria. So our diagnostic criteria are always going to identify males more strongly than they identify females. Another thing that we can think about is we have different expectations on how different genders socialize and play. So even if a boy or a girl are expressing the same behavior, it might be socially acceptable in one gender and not in another. Examples of these differences are that boys tend to have more externalized symptoms that are more obvious to their caretakers, while girls tend to have more internalized. Boys are more likely to have hyperactivity or aggression, while girls are more likely to have anxiety and shyness. And boys are more likely to have communication deficits, while girls are more likely to have better language skills, especially verbal language skills. Boys are often expressing more intrusive behaviors that are interrupting other people and more obvious, so their behaviors are much more likely to be noticed. Girls had these more internalized symptoms, and one thing that's really interesting is that girls tend to be able to camouflage their social deficits better. We call this masking, which is mainly just pretending. So mimicking other people's social interactions and social behaviors, even if it's not necessarily natural to the girl themselves. A great quote about ASD is, "I'm autistic, which means everyone around me has a disorder that makes them say things they don't mean, not care about structure, drop weird hints, and creepily stare into my eyeballs. So with that quote, we're going to wrap up this lecture. Thanks for sticking with me.